And with that, it gives me great pleasure to introduce our first speaker, Professor Seung Ho Han. Professor Seung Ho Han is at the EWHA Women's University School of Medicine. He's chairman of the Korean Association of Anatomists, a former professor at two other eminent universities in Korea. And he's the author of numerous published articles. And he's going to be bringing us today essential anatomy for minimally invasive procedures. So, Professor Han, it's a great pleasure to have you here with us. We're very honored, and we're looking forward to your presentation.
For your kind introduction, and then it is my honor to have a chance to present at the first the Jetema academic meeting. Today, my topic is the facial anatomy for the minimal invasive procedure. Everyone here? Okay. So, minimal invasive treatment are now a common trend for the aesthetic or anti-aging procedure in clinic. For the successful minimal invasive procedure, we must know about the surface anatomy, and then we can imagine the structure under the skin. If you imagine the lady comes to your clinic, so you can imagine the facial bone as a skeleton beneath the skin, and the facial muscles and vessels and nerves. So understanding of facial anatomy is very necessary for good result of minimal invasive procedure on the face. So I want to talk about the key point about the surface landmark and the danger zone of the face. So just like the structure of the scalp, as you know about the scalp is 5 layers. So you know the 5 basic layers of face is skin, subcutaneous tissue, SMAS or miming muscles, and then deep fat layer or space, and the last one is deep fascia or periosteum. So layer 3, the SMAS or miming muscle is the most important criterion. From this layer, we can distinguish the layer 2 and layer 4. And then for the lifting, this is the main focus. Everyone knows about that. SMAS is a continuous flat structure from the platysma to the galea aponeurosis. But the SMAS has a slightly different shape and structure according to the regions. SMAS is well formed on the lateral side, especially, but wrapping with the miming muscles, SMAS becomes weak and poor developed on the medial side of the face. So we can use the lateral side of the face for the lifting and the medial side for the the focus for the volume augmentation. You can see that this slide, the elasticity and the movement of the SMAS. This is from the soft cadaver. And this photo is from the involved cadaver. You can also see the SMAS as a one single plate structure. Okay, layer 2. The second layer is the subcutaneous tissue as a superficial fat compartments. This layer have hypertrophic process with aging in general. We can divide by 2 types with different composition of this layer. Especially type 2 has more collagen fiber and relatively tight structures. These different mechanical property between 2 types make the skin crease more easily. The type 2 superficial layer is especially the focus on that periorbital, nasal, and perioral areas. So the most prominent demarcation lines as you know, the nasolabial fold or labiomandibular sulcus or submental sulcus, marionette line, like this, the phenomenon makes the result. The layer 4, the deep fat compartment layers. This compartment is sometimes some species they have space. Some other the position is that they have that fat tissues. These fat compartments have atrophic process with aging. So we can use this layer is the major target for the clinician with facial augmentation. And another one is this layer is a turnover time is around 10 years, relatively longer than the layer 2. Another structure is a retaining ligament or the septal or adhesions. This overall structure makes the compartments. The main function of this structure is that stabilize the soft tissue of the bone. I want to show just one true ligament from cadaver as a sample. You can see the strong and well-developed zygomatic ligaments. The septal or the linear ligamentous structures provide the holes for the roots of the nerves and the blood vessels. We can't name the septal, but or the linear ligament, but their structures are not the complete blocked barriers. We can see the overlapped two-layered fat compartments, layer 2 and the layer 4 overlapped. This is another the pictures. That we can imagine two overlapping two-layered superficial and deep fat compartments by septa or the ligaments. These structures make the skin crease and the stigma with the aging face. I like these figures. This is very good concept, well, the illustration. The smash is like a floor, so the smash is the barrier. From the smash, we can find the layer 2 and the layer 4. Also, septa and the ligament has like the wall of the building. Especially, the nerves and the vessels can use that major route for the transition from the deep to superficial. The layer 4 to layer 2. So everyone knows that the facial lobe is a motor nerve for the miming muscles, and their main position and their start is layer 4. But the temporal branch, especially above the zygomatic arch, is particularly very weak and very novel. So because it became the more superficial and travel on the undersurface of the smash. So you can see the representative, the historic section, and then the schematic illustration of these regions. You can see the very close to the smash with the temporal branch of the facial lobe. This is another sample slide, and then we can make a danger area of the temporal branch of the facial lobe like this. So I want to say that pay attention, especially above the zygomatic arch. The facial lobe is particularly very weak and very novel. Another the branch named the zygomatic branch, especially the branch at the inferomedial or medial part of the orbit. Their course also superficial than the miming muscles. So we need to pay attention if you want to inject the dermal. The next structure is a facial artery. facial artery is like the same. The starting point is layer 4. But the branch is also the transition from the deep to superficial association with the septa or the retaining ligaments through the layer 4. We can imagine the main branch of the facial artery on the patient face like this, but one important point of facial artery is which area is that the artery is located on the layer 2 using the septa or retaining ligaments. You can see this slide, the color is different, and then you can see where is the layer 2, the facial artery located on. And the percentage of exposure of the facial artery on the facial muscles, it means layer 2, are very important. And then you need to pay attention when you inject the filler on this area. This area including the angular regions, and then alar, and then superior, lateral side superior rib. Okay. By the way, the main and the severe complication of filler injection on the face is the blindness, because the many internal carotid artery branches around the orbit, anastomosis with the external carotid artery, like a facial artery. So we know most about that the anatomy and the anastomosis patterns. So especially, I want to say the 3-point nasolabial, and then dorsolateral, and then supraorbital part. This slide shows that distance between the nasolabial fold and the facial artery. The average distance about 3.5 millimeters, but the standard deviation is about 5.5 millimeters. What this means? So this is the types and then percentages. The course of the facial artery may overlap with the nasolabial fold about 40%. You can find that there are many ways to avoid the injection filler to the facial artery, but most important thing is to inject slowly. The gentle maneuver is strongly recommended in these regions. Another one is alar part of nose. In this region, the facial artery runs on the layer 2. And another one is this area is very tight histologic structure, and then it can make the ischemic necrosis after injections. Next slide, I want to say about the labial artery. This is the depth and then the distance from the mammalian borders. So the superior labial artery is located within the 1.5 centimeter side square superior lateral to the mouth corner, and the depth is around that over the 3 millimeters. So average 4 millimeters depth they have. So if we want to inject here, you must take care about that. The injecting the dermal filler at this area, you must be careful. Okay, on the lateral side of upper lip, the facial artery on the auricularis oculi, the percentage is about 70. So compare with the superior labial artery, the inferior labial artery is they have the size, the diameter is relatively small, and then they have distance from the mammalian border. And superior inferior labial artery found in the submucosal layer. That means that the muscle layer and then the mucosal part between that. So if you inject superficially, the mammalian border of the superior imperial ribs are relatively safe. But please take attention about that the close to the mucosal area is dangerous. Another one is I want to say about the submental artery. This artery is relatively rare attention to, but some complication on the chin regions, because as a nasal tip or alar lesions, they have the tight composition. So this area also make the ischemic necrosis also. Okay, the most potential area, the directly affected is the branch of that the internal carotid artery is a forehead area. The main artery from the forehead is the supraorbital and the supratrochlear arteries. So we need to know the position, the main branch of those arteries. But there are very simple reference landmarks from them. For the special, for the supraorbital artery is the landmark point is the medial limbus, and the medial canthus is for the the supraorbital artery is the medial limbus, and the medial canthus is for the supratrochlear artery, right? But the supraorbital artery is more superficially located than the supratrochlear. And another danger area is the point of the anastomosis between the supraorbital and the superficial temporal arteries, like this one. And you can see there are many the anastomosis point between two arteries. So let me show that illustration of the anatomic connection between internal and external carotid artery as a summary. Facial vein is similar, the root, but more directly course from the mandibular margin to the angular portions. And the average distance from the nasolabial fold is larger than the facial artery and the deep. So it means the facial vein is relatively safe if you inject near the nasolabial fold. Okay, next slide I want to talk about the trigeminal nerve. There are many the reference point of the trigeminal nerve, or the opening or foramen or notch, but we can use the same reference landmark of nerves with artery in forehead. For the supraorbital nerve is medial limbus, and the medial canthus is for supratrochlear nerves. Very simple and very useful. Supraorbital nerve divide into the superficial and the deep branch, especially most lateral part. The deep branch runs beneath the frontalis. They are all courses. So we need to pay attention when you focus on the forehead, especially lateral side. But the territory of these two, the nerves, the lateral caruncle or lacrimal caruncle or medial canthus is a very good landmarks. In case of the mental foramen, I want to say the very good landmark is the second premolar. It is different from the premolar to the mental foramen according to the aging, because especially the mandibular is a dentition, and the other condition makes that the distance may be changed. But you can find that the point, the premolar is always the continuous. The last one is the lateral canthus is also very good landmark for the zygomatic-facial and infraorbital. In my research, the lateral canthus is very good because the lateral side of the lateral canthus is the territory of the zygomatic facial, and the medial side is infraorbital nerves, almost 100%. So you can use that nerve block or the anesthetic. So last, I want to say about that. Everyone has a different shape of face, but the starting point is skeletons. So the skeleton is everyone has a different types. So please imagine about the skeleton beneath the skin. I want to say once more. And the last one is that, so there are so many vessels on the face. As I'm the anatomist, there is no the safe area. But if you inject the gentle maneuver with it, gentle maneuver, is you can have a very good result. So today is my topic is finished that. Once again, thank you very much for the attention.